My name is Bilsborough. I'm the information analyst, well, one of the information analysts at Newcastle Hospitals. I'm also part of Collaborative Newcastle, which is kind of a partnership between the hospital, our mental health trusts, local mental health trust, CNTW, and Newcastle City Council. So first off, a bit of background. I'm not sure why this isn't moved. There we go. So as part of the 2021 census, that I've kind of bounced the 2021 census off the 2019 IMD, and we found that about a third of the Newcastle population is within the national core 20. Physically, it's kind of focused along the river there, along the bottom of the town, but then also kind of to the north of the town centre. The kind of more urban areas, for want of a better description. So we also consider that, well, it's up to you which way you look at it. Within the areas that are the most deprived, they have a much lower overall life expectancy. So we can see that for men, it's bang on 10 years lower in Elsie, which is kind of there-ish. And Biker is over here, and that's, what's that, 9 years for females. So there we go. So as part of a kind of wider way to kind of hopefully tackle both deprivation and poor health outcomes, the wider determinants, kind of everything follows everything, as we all know. DTP is a Newcastle City Council wide programme, which is part of Collaborative Newcastle. It consists of a multidisciplinary team made up of a public health consultant who's kind of in an advisory role. Then we have a care facilitator, a matron, a health economist, a data scientist, and a data analyst, and we have an admin assistant. We're also part of one of the national academic academic health science centres. So a general workflow, and I'm kind of battling through this to get to the interesting bit. We start off with data from all three providers. It's analysed, cohorts will be identified. This is kind of as far as we've got, really. We've had a lot of problems getting the data set together. Understanding is going to be kind of added in. We've got economic analysis, and then hopefully long-term system transformation, working between council teams, health teams, mental health teams, making sure that if an individual has a given problem, we can kind of join up and make sure that they're getting the care they need, but also it's delivered in a more efficient way than perhaps it is at the moment. So the data flow is between Norfolk Council and CNTW. They all have their own servers that will get mushed into my DCP server. I then build a bunch of Power BI dashboards, which we'll be coming to. Our data scientist only joined a month or two ago, but she'll be doing a lot of Python and R, and then obviously you can run custom queries through SQL. You can do whatever you like there. For people who are kind of interested, which maybe nobody, I'm not sure, we use an entity attribute value format for the transfers. So that gives us flexibility on, these are custom feeds, but you can see here, this is all just one record. So at the end product is this is just one row. But because I have the data item description and the data item order, makes it very easy if there were extra bits of data that we wanted to add to, just give it a new data item order, and then when the pivot times it comes kind of pivot it at the end, you just have more rows at the end. So you can kind of flex and throw extra bits in pretty quickly from a design point of view, which is quite nice. So this is just an outline of what we actually have. So we have inpatients, outpatients, A&E visits from the queue, community visits, community appointments for the services, community services administered by NUF, which is one of the things where we think we can do something duplication-wise between that and probably the adult social care, or even within community. The walk-in centres are kind of like more grade A&Es, they're also in the community feed, but any outpatient services in mental health and adult social care, children's social care, so children in care, any early health plans, children with low school attendance, obviously at the council schools, so private schools aren't in there. And then we do have a whole housing and homelessness feed. Everything else links on NHS number, housing and homelessness at the moment is kind of on a footing joined by a bunch of like little name matching algorithm I've written and date of birth. What I want to do, as the previous man before said, it's all lighting at the end of the day, isn't it? I want to be able to bounce it off the spine, which is one of the many things I'm slowly working on with our hygiene teams. So the data set in all contains about 300,000 individuals, which is about 2/3, I think, of the Newcastle population. Off the top of my head, 3 million contacts in the last 2 years. About 1,800 have had contacts with all three. You can see the vast body of it is North End. About 2/3 of those are just A&E contacts. So really, once you kind of scrub the occasional A&E contact out there, things become a bit more focused in, and you can start doing some analysis. Basically, a lot of people have only one contact or maybe two, and they're both with A&E, so you can't really derive a lot of insight from that. So there's things that we can start doing, and we've not done any very clever analytics yet. I built some dashboards. I'll give you a quick kind of tour of the dashboards. So this first one gives us this big list of every service in my data set here. I've chosen health visiting, which to be honest is one of the least interesting ones, but it gives you can very quickly kind of grab what's going on here. We get the health visiting users, there's not quite 9,000 of them, and this is where else do each of these individuals go. So, no great surprise there, other than ED, which everybody goes to, paediatrics, well, babies, all that sort of stuff, paediatric speech and language. I mean, there's potentially this bottom one here, oral surgery and dietetics might be a bit unusual, ENT might be worth digging into. Some of them are a bit more interested, I want to say. So this one shows us the geographical distribution of service users. I've had to do some kind of rebasing to get, because the LSO has moved between censuses, but the IMD obviously is using the old LSOs. I've had to do some kind of rebasing behind the scenes. You can see there, so this is adult drug and alcohol service, which is one of the mental health trust services. We can see here physically, and I don't expect you to 90% the same word for it, but these, it kind of follows the deprivation map that I showed you at the very top, especially this area and this area, which is Bath and Elsig, the two very lowest life expectancy places we were talking about before. This graph here, the red line is the services distribution along the IMD deciles. So, and the blue line is all service users, the dark blue line is our population. So you can see here, roughly, for your lowest IMD people, they are twice as likely to be in there as the population kind of would imply, if that makes any sense. The distribution is way skewed for drug and alcohol at the lower end of the distribution. I can also do things, so we're still on drug and alcohol. User density is the same, but then we can map things like localized DNA rates. And that is, for the drug and alcohol one, it's elevated across the board. We can also do things like this. So this is a little heat map of how many other services the users of this service use, again, by IMD. So you can see here by the heat map, and I mean, some of it is just the number of people in there. This all needs to be controlled for. We can see here, this is clustered, so we have a cluster of between 2 and 9 users, other services used. That's enough, that gives you an idea of the other services they use. So we can see here, so lowest IMD, not only the number one service is ED, over half of them are using ED, and then it's the homelessness team, the telephone triage team, which is kind of the front door of the mental health service, hepatology, oral surgery, internal medicine and temporary housing. So you can see there's a link there between your drug and alcohol services and your homelessness service, which probably isn't a surprise, but it's nice to know that things work. We can also group by LSOAs. We group the LSOAs into council wards, and I've just kind of put this in. This is something I've only just kind of started on doing. I'm not there's somebody doing something really clever with fingertips before that I'm stealing off them already when I get home. So we can map the LSOAs to wards and then do things where we can bounce it off APIs like fingertips. There's other APIs that I need to get in there. But we can see here for, where's that, Walker, one of the most deprived areas of Newcastle for fingertips, and this kind of maps, obviously, they're not doing very well compared to the England average. And my next step here is to kind of map these onto the service use, which is something I'm going to do next week. I was hoping to get a little further on with this, if I'm entirely honest, before now, but it's all patchy at the end of the day. I think that's about it. So opportunities, there's lots of potential for the sort of AI machine learning approaches. We've started working with the National Institute for Data, which is in Newcastle as well,
2 minutes.
to build a maternity service prediction tool. So kind of where other people who are falling off the maternity pathway are being poorly served by maternity services, what other service uses indicate that that newcomers to the service are going to be in need of extra help, and that's kind of where our mentoring is going to come into things. I'm working on some primary care integration to get diagnoses into there, which has been a bit of a nightmare, but hopefully we're getting somewhere with it. Place-based work with essentially councils driving that. There's something very interesting that I'm going to be kind of mapping this over around workforce for 3 main organisations to kind of see how health and employment interact. That's very, very early days. And then, yeah, just a general opportunity is that the way that this data set has been structured is you can throw APIs against it pretty easily. It expands very, very easily as long as the data exists in the provider side, which is a different kettle of fish. I think that's about it. Thank you very much.